Good morning, all of you. Welcome to the CPD webinar series organized by the Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:55 a.m. to join in. No late attendees will be entertained thereafter, and each attendee should have attended till the end of the webinar to obtain the CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. You will instantly receive the e-certificate once you fill the Google form, so kindly use the format of initials followed by surname. Don't use prefixes like Dr. or Mr. And these housekeeping rules are to improve and maintain the standards of the CPD programs conducted by SRI. Thanks in advance for your strict adherence. Question time will be at the end of the webinar. If you have any questions, please type it into the chat function. And if you have very specific questions, please email us on office313@gmail.com. So today's topic is refractive errors. And our guest speaker is Dr.Medhavini Dissanayake, Acting Consultant Eye Surgeon at National Eye Hospital, Sri Lanka. Over to you, madam.
Good morning, everyone. Today I am going to talk about refractive errors of the eye and refresh our knowledge on what we studied for MBBS and some other updated information. So I have references from American Academy of Ophthalmology clinical optics book, and also I have taken photos from the public domain. So let's recall how the eye focuses an image on the retina. So the eye has two components which provide the refractive power, the cornea and the lens. So the cornea provides the majority of the refractive power, 2/3, and the lens provides 1/3 of the refractive power. Apart from these two elements, we also need the proper placement of the retina. The retina where the image forms should be at the focal length of the refractive elements of the eye, the cornea and the lens basically together. So you need a proper axial length that matches the refractive power of the eye. So these three are the main elements that provide a proper focused image of the eye. Now let's look at, let's recall something about accommodation. Our eyes have the ability to focus on distance objects as well as near objects. So this is by increasing the focusing power of the lens. So you increase the whole power of the eye by increasing the power of the lens. This is achieved by changing the shape of the lens from thinner lens to a spherical lens. So in childhood, you have about 15 diopters of accommodative power. Or your lens is able to become a much bigger sort of rounder sphere. But as you age from birth, your ability to accommodate gradually decreases. So at one point, you become presbyopic, and we will talk about that later when we discuss presbyopia. Now, just out of interest, snakes, they cannot change the shape of their lens, but they move the lens backwards and forwards in order to focus on near and far objects. So refractive errors, what are they? Refractive errors are problems that lead to defocus or blurred images because of mismatch of the corneal lens and the axial length of the eye. So also either it is due to a mismatch or due to inadequate functioning of these refractive elements. So like I said, the three components have to be working properly and match each other to provide the proper focusing of an image. So mismatch we call ametropias, can be axial, that means the length of the eye is the problem, or it can be refractive, meaning there's a problem with the refractive elements of the eye. So according to the problem, you can classify them as myopia, hypermetropia, astigmatism or presbyopia. Myopia, hypermetropia could be axial or refractive. Astigmatism is commonly due to a problem with the corneal shapes. We will discuss that later. And presbyopia, like we said, is a problem with accommodation. So myopia where is a refractive error where the distant objects actually focus in front of the retina. In normal eyes, they light rays coming from infinity focus on the retina, but in myopes they focus in front of the retina. So you can see that it can be, like we said, a refractive problem or an axial length problem. So axial length meaning the eye is longer than normal. Normally it is about 24 millimeters from cornea to the back of the eye, but in these patients it can be 26 millimeters, 27 millimeters, like that, longer. So the refractive elements don't match the axial length of the eye. But in other conditions, you can have very steep corneas that can provide a higher refractive element, but the length of the eye is normal. So those you call refractive myopias. So in these patients, the far point is actually nearer than in a normal eye. So in a normal person, the furthest point that they can see is infinity. But in these myopes, it has now come forward, and with a relaxed lens, they can actually see objects that are close by. So that's the furthest they can actually see. So because of that, myopes generally tend to take their glasses off to look at near objects, and they don't generally require reading lenses to look at near objects. So types of myopia, earlier we used to talk about adult onset and juvenile onset myopias. Now we generally say non-pathological or pathological. Non-pathological ones are the physiological or simple myopias, and pathological ones are the progressive myopias that lead to vision loss. Non-pathological ones, they don't progress a lot. There is some amount of progression, especially during childhood, but when they are in their 20s and in basically the second and third decade, by the end of the second decade or the early third decade, this kind of stabilizes and doesn't progress. So the onset, like we spoke earlier about juvenile onset and adult onset can be variable, but the picture is that it doesn't really progress like the pathological one. Pathological one, it progresses a lot. So basically the globe elongates beyond the normal growth phase of the eye. So the eye does grow during childhood and maybe early teenage years somewhat, but in these pathological myopias it continues to grow. And because of that, there is thinning of the retina and problems associated with the retina mainly. So there is atrophy, diffuse or patchy cracks that can appear just beyond the neurosensory retina, and there can be bleeds, and associated neovascularization. These can also, especially the atrophy and the neovascularization, later cause scarring and blindness. The myopia itself is very high usually in these patients because the eye keeps on growing. Their refractive error is by definition generally beyond -6 diopters, but pathological myopias generally have like -12, -15, 19, things like that, and they may not have a correctable vision of 6/6. So even though you correct the refractive error with by convex lenses, they still may not achieve 6/6 vision because of these retinal issues. So what are the risk factors of developing myopia? So as we know, genetic factors play a major role. We all know that if the parents have myopia, the child is likely to have myopia. The degree of course can vary, And also some ethnic groups are more susceptible than the others, like the Chinese population. They are more likely to develop myopia. Almost 80% of in some countries are myopes. But of course, you can't strictly blame the genes. Sometimes these ethnic groups or even families can be can have different environmental factors also playing in that society or culture. So you can't really pinpoint at genetics as seen by some studies. What are the environmental factors? Near work, of course, has been associated with development of myopia. So especially this adult onset myopia, during their childhood they have completely normal sight, but when they're in their 20s, early 20s, doing higher studies and more hours reading, some patients tend to develop myopia, the simple type. So there is a clear association. Also, near work during the first 2 years, especially in a genetically susceptible individual, can lead to maybe progressive myopia as well. So these studies have actually only shown association with these other things like higher intelligence, urbanization, and certain types of diet. There's no direct link, it's just associations. Nutrition, of course, in highly malnourished populations, such as patients in Africa, which we don't really see in Sri Lanka, there is a susceptibility to develop myopia. So these are the main risk factors for the development of myopia. There are, of course, syndromic associations with myopia as well. These syndromes can be systemic ones or limited to the eye. So keratoconus or ectasia of the eye, which we are going to discuss later a bit, is associated with myopia. Congenital glaucoma, retinopathy of prematurity, retinitis pigmentosa, cataracts, congenital stationary night blindness, and these kind of rare diseases, eye disease, gyrate atrophy, albinism, and other conditions limited to the eye like Stickler syndrome, diabetes, Marfan's. These are connective tissue disorders. So you can see that the connective tissues in the sclera would be affected, causing elongation of the eye and development of myopia. So how do we prevent? Most patients, especially if they are having myopia, they would ask this question about their children. How would they be able to prevent the child needing spectacles? So one of the important things, so from these studies regarding association and risk factors, is that if you do more outdoor work, your requirement of accommodating the lens is less. So because of that, the development or progression of myopia would be less. Sports, outdoor sports, the same mechanism. Computer work and games actually haven't really shown a correlation between development or progression of myopia, but of course it is beneficial to limit one's time spent on computers. There are other things like the Me-Sight contact lens, the recently FDA approved thing that has a component to provide near vision and distance vision, and thus limiting the requirement of accommodation. This has also proved beneficial to prevent development and progression of myopia. Atropine, by the ATOM studies, they have shown that atropine drops, 0.01% drops, can actually be beneficial in preventing myopia. So currently we are not really doing these things, I have not seen, but in childhood, if you detect early, they would be beneficial. So management of myopia, is mainly, like in all refractive errors, mainly spectacles. So especially in childhood, you would want to give them spectacles. So you give a concave lens as a spectacle correction for distance vision. This is the phakic IOL, which is another option for very high myopes. This is a lens that we put in between the crystalline lens and the iris. So you have the natural crystalline lens that we are born with is there, so you do not lose accommodation like in a normal cataract surgery would. So you have preserved accommodation, and on top of that you have a lens now to keep you off spectacles. Basically, it's a good method of correcting high myopes, and patients are generally quite happy with the results. Because they are spectacle free. Of course, for to use that kind of thing or the other mentioned things like contact lenses, the patient has to be old enough to be contact lenses, especially to be responsible and take care of them. Phakic IOL, of course, you have to put once the eye is stable and you know for the fact that it's not progressing, because it's an intraocular procedure, it's surgical procedure. Laser procedures also, the eye has to be stable to do. Laser procedures we will discuss at the end. So hypermetropia is a refractive. Now we have come to the second refractive error. So hypermetropia is when the distance object or light rays coming from infinity are now focused behind the retina. Myopia was when it was focused in front. This is where it is focused behind the retina. So you can see that it can be either due to either reduced focusing ability of the cornea or the lens, or because the eye is now shorter than normal. Normal is roughly about 24 millimeters. So these eyes can be 22, 21 and so on. So now there are certain conditions like nanophthalmia and microphthalmia which are extreme causes of hypermetropia, where the whole eye or the anterior segment of the eye is formed in a very small scale, let's say. So the eye is actually short because of that. So we are not going to discuss those things, but generally general hypermetropia, not the extreme cases, is due to short eyes. So the problem with hypermetropia is that people can, because the lens is able to accommodate, people can overcome a certain amount of the refractive errors. So maybe about +1, +2, depending on their age and their ability to accommodate, they can overcome the hypermetropia by accommodating when they are looking at far objects. Now, especially during childhood, where there is a big range of accommodation by the crystalline lens. Now, because accommodation is associated with convergence of the eye, when they accommodate, the eyes will converge and you will see a convergence squint. So in children, one of the reasons for the squint can be hypermetropia, and if you correct the hypermetropia, the squint will automatically correct itself. The other important thing about childhood hypermetropia is that because they can't focus far objects and also near objects, they are likely to develop hypermetropia. Amblyopia, which amblyopia is a condition where the structure of the eye is normal, but the brain does not take up the signals of the eye because you have the eye has not given properly focused images to the brain during the brain's development period. So during this is the childhood, we are talking about maybe less than 7-8 years of age. If the eyes don't produce focused images, the brain would try to ignore that eye, the signals from that eye. So when they are older, even if you correct these type of errors, the brain has not developed the ability to gain these signals, so you develop amblyopia. In myopia, of course, because a child is able to at least see near objects, the risk of amblyopia is a little less. So, for hypermetropia, these are some of the risk factors associated: maternal smoking during pregnancy, prematurity, low birth weight, and hypermetropia is associated with rural living as opposed to myopia being associated with urbanization. Excuse me. So, the management options are the same as we spoke for myopia. Spectacles, you are giving biconvex lenses this time to give additional power, refractive power to the eye, so that the eye can now converge the rays onto the retina. Contact lenses again, and refractive surgery, we will talk about that later. Now the third refractive error is astigmatism. This is also commonly seen refractive error. So, what is astigmatism? The astigmatism is a disparity in the focal length of rays coming from different meridians of the eye, right? So, lens here, I put lens because what I mean is the refractive element. So, what happens is, now if you take the cornea here, the cornea is steeper in this vertical axis, but that is shown in red. But in the horizontal axis, you can see that the cornea is a bit more flatter. So, the ability to refract is more in this plane, in the vertical plane, than in the horizontal plane. So, the images or the light rays that come and refract through this plane focuses in front of the retina, whereas the images that go through this plane actually focuses maybe on the retina, depending on the type of astigmatism, or somewhere else. So, basically you get a really blurred image because the refractive elements are now different, and each refractive ability is different to each meridian or cross section of the eye. So it's like it can be explained through these balls. Like one is a football and the other is a rubber ball. The football, it's a perfect sphere. So all the meridians or axes have the same curvature. But if you take a rubber ball, you can see that the vertical curvature is more than the horizontal curvature, or more steeper than the horizontal curvature. So, if these were lenses, you can see that the rubber ball would have more convergence in the vertical axis than the horizontal axis, whereas the football, if it was a lens, it would converge in the same spot, all the light rays. So, normally in our eyes, we have something called with the rule astigmatism. So, our eye is not really a football shaped one, so it's not a perfect sphere. It's actually like a rubber ball on its side. So basically, the vertical axis is steeper than the horizontal axis. This is normal. Everyone has a bit of with the rule astigmatism. But if it is very steep, even though the two axes are like this, if the vertical axis is very steep and requires a lens for correction, then you call it with the rule astigmatism, which is a type of regular astigmatism, right? So, we have now types of astigmatism: regular and irregular. Regular means there is some kind of order to this astigmatism. So, with the rule is with the normal rule that is seen in the normal eye. So, it's a football on its side, it's just exaggerated. Against the rule means a football on its point or vertically kept football. That means that unlike this eye, you are now having a shallower vertical axis and a steeper horizontal axis. So, that is what you call against the rule. the third one would be, now instead of the astigmatism being vertical or horizontal, now with the rule and against the rule, it was always vertical and horizontal axes that we were talking about. But in oblique astigmatism, now we are talking about an oblique axis, right? So in the top picture, you can see with the rule astigmatism, against the rule astigmatism, the dark blue showing the steeper curvature, and in the third picture you can see oblique astigmatism. So one of these meridians would be steeper than the other, not both. So that is regular astigmatism. Irregular astigmatism is when the cornea is very irregular and it doesn't really follow a pattern of these rules. So you have something that doesn't fall into any of these categories, is very irregular shaped. So what causes irregular astigmatism? Things like corneal scarring due to any reason. Could be an old trauma, ulcer, suturing, maybe a scar from old surgery. Then another big problem is the ectasias, keratoconus, and other ectatic diseases like pellucidity margin degeneration, keratoglobus, things like that. Corneal dystrophies and corneal degenerations. These are other causes of irregular astigmatism. So for regular astigmatism, the management options are spectacles, contact lenses, and refractive surgery. For irregular astigmatism also, you can correct to some extent with spectacles, but it might not give them the best corrected visual acuity of 6.6. But contact lenses, on the other hand, have the ability to correct astigmatism better than spectacles, because it now kind of sits on the cornea and generally has a way of sort of changing the cornea surface right at the site. So for irregular astigmatism, certain irregular astigmatisms and very high regular astigmatisms, you can try contact lenses, which will be better than spectacles. Refractive surgery and other lamellar type of surgeries may also benefit certain types of astigmatism. So to correct astigmatism, what you use is something called the cylinder. Now cylinder along its vertical axis in this picture doesn't really have a curvature, but there is only a curvature or the ability to converge only in one axis. So this is different to a sphere. So when we are prescribing a cylinder for astigmatism, we have to always mention an axis, because it can be the eye. There's a nomenclature of axes. So basically, it can be the vertical axis or horizontal axis, and you give a value 90 or 180 or 150 or something like that, where the cylinders should sit. Right? Unlike the spherical errors, myopia and hypermetropia, cylinder has an axis where it has to sit. Right, let's get to presbyopia. Now we spoke about accommodation and how the eye is able to accommodate more during at the time of birth and early childhood, and how it gradually decreases with age. So you can see here how a 5-year-old would have roughly about 15 diopters of accommodation, and therefore the nearest point that they can see is actually 5 centimeters. But as you become 10 years, the amplitude of accommodation now starts to decrease, and now your nearest point is a little bit further away, it's 8 centimeters, and so on. So the near point actually starts moving away from your eye. So at 40 actually it becomes 25 centimeters. So 25 to 30 centimeters is normally where we keep our reading material when we are reading. So this is the age when we start to notice that we can't see near, because now it's affecting the reading distance. So that's when we say you need reading glasses and you have got presbyopia, although accommodation was starting to reduce since birth. And then after 40 it continues to drop further and you lose it completely maybe at around 60-70 years, the ability to accommodate totally decreases. Right. So, this is the same slide I showed you earlier. So, at 40 is when you start to realize that your accommodation is lost and that you need reading glasses. So you give a more powerful lead, like a plus, you start off with a plus 0.5 diopter lens at around 40, and then every 2 to 3 years you change the lenses and make give a bit bigger ad till you go up to about 2.5 diopters. So when you prescribe for reading ads, you can give them bifocals. So bifocals or these the bifocal type of lenses have actually a demarcated area for the reading reading error and a demarcated area for distance vision. So intermediate vision you don't really have in these types of spectacles. Then you have the progressive additional lenses. These are there is a graded power in the lens. So for the top part you have distance vision correction, the bottommost part is for reading, and then intermediate vision you can get from here. So from infinity to the near object, that the objects in between you can see from this middle part. So these are the two types generally that we see. The importance is that when you are prescribing these spectacles, somebody who is used to wearing bifocals, so when they were 40, somebody would have given them bifocals, and now they have come for a change in spectacles, and now you can't give them a progressive lens because it's hard for them to adjust from bifocal to a progressive additional lens. But if at 40, when they started off, you gave them progressive additional lenses, they can tolerate it for longer. Progressive additional lenses have a lot of image distortion in the periphery, so you have to warn them that they will see the images will be distorted immediately when they start wearing, but after a while they get used to it. There are bifocal contact lenses also available, but they may not be very good, at least the ones that are available to us. So like I said, every 2 to 3 years you need to change your glasses when you are in after 40 years. So maximum ad that we recommend is plus 2.5, plus 3 also you can give if the patient can tolerate, but by now the patient has totally lost their accommodation ability. So at this point you might actually recommend them a cataract surgery because they are likely to have age-related cataract, and by removing that cataract their distance vision and will be corrected, and they will have better ability of tolerating a 2.5 diopter reading glass. So here is a spectacle prescription. I have just added this so that we all know what we see that is sent by the optometrist. So here the first bit is the sphere or the spherical correction that is given. So this is for myopia or hypermetropia. Here this patient has not needed any spherical correction. So basically he is not a myope or a hypermetrop, but he is having astigmatism. Both patients. So here you can see the cylinder in the right eye is minus 2.5 and the axis is at 40 degrees. Here the cylinder, the left eye has less astigmatism, it's minus 0.75 and it is at 140 degrees. The best corrected visual acuity with this prescription for the left eye is 6.6, but the right eye, your maximum correction in the Snellen chart is 6.9. And you can see maybe it is due to amblyopia because the pinhole also has shown 6.9 maximum. This is probably a young patient because there is no ad for reading. In the second patient, again the spherical correction is 0, so he is neither a myope or a hypermetrop, but there is a minus 0.5 cylinder for astigmatism for the right eye, which has given a 6.9 plus vision. and this you can see they have given the maximum reading at of +3. In this patient you can see that they have a plus sphere here and a big cylinder of -6 at 175, giving 6 minus vision, whereas plano or a plain glass has been required for the left eye. This is a bit abnormal, we will come to that. So, how do patients with refractive errors come? They generally complain of headache, especially young children, and they will complain of reduced distance or near vision. They will say they cannot see the blackboard or they cannot read. And some children, of course, present with squints, as we told earlier. So, if you don't treat them with spectacles, if you don't detect them actually early on, children can develop amblyopia. If the patient is having keratoconus, it will progress and cause corneal scarring and requirement of thick or full thickness corneal grafts. And in progressive myopias, you may develop irreversible damage to the retina. So, other important thing that we may miss is that even though they may not be having refractive errors, they would be suffering from a defective visual acuity because of dry eye. So, you might want to consider dry eye disease, especially in this day and age where we use a lot of screens to do our daily work. Let's talk a bit about keratoconus. So, keratoconus is a ectatic disease. So, basically the cornea gradually becomes thin. So, this starts off in very young children, generally in their teens, but it can appear in a younger age group as well, maybe 10-year-olds, but generally in the teenage years. And it is a progressive disease and generally bilateral. So, what happens is the thinning, the corneal collagen basically is not stiff enough to withhold the eye pressure. So, it just gradually becomes thinner and protrudes outwards, producing a cone-like shape to the cornea. So, the problem with keratoconus is that because the shape is now different, the cornea's ability to refract is changed. So, they will present initially with myopia and maybe astigmatism or astigmatism alone, but gradually the ability to correct up to 6/6 will be lost with spectacles or contact lenses. Contact lenses, the tolerance is also difficult in this patient because the shape is now abnormal. So, you can see here in this picture the white opacification of the eye in something called hydrops, where the posterior most layer has now broken because of the thinning of the cornea and protrusion and basically the stretching of the posterior layer. It has now kind of snapped, and all the aqueous humor has now got into the corneal stroma, and there's hydration, and you can see the scar here. The hydration, opacification, and later it will scar. So, this is mainly opacification due to hydration. So, this is the progression of keratoconus. So, this is not what we see early in the disease, but in the later stages. So, progression automatically stops in the late 20s, maybe early 30s. Because of natural aging processes in the collagen molecules. So, for the treatment of keratoconus, we use this same aging process, which we do. We do an we expedite it and use artificial methods of cross-linking the collagen molecules. And then basically what we do is we stiffen the cornea, and the corneal disease progression is stopped. But the damage that has already been done cannot be reversed. Again, this with collagen cross-linking, which is the treatment option, we can stop the progression, but we cannot completely recover the eye back to normal. So, collagen cross-linking can only be done if you catch the disease early at a stage where spectacles or contact lenses are able to correct the visual acuity to the required amount. But if it is now progressed beyond satisfactory vision correction for the patient, and the cornea is too thin to actually do this collagen cross-linking, then we need to do surgery where we do a graft. So generally we do something called deep anterior lamellar keratoplasty, where we only replace the anterior stroma of the cornea with the donor cornea. So this is definitely more invasive, and this is a lifetime commitment for the patient when your eye is grafted. So collagen cross-linking, if we could do, which is just a small procedure where you put riboflavin drops and then you expose the eye to UVA rays, and you stiffen the cornea. This is a much smaller procedure, and once it's done, and the patient can go back to their normal lifestyle. But once the eye is grafted, the patient will have to use long-term medication and have to be careful, because the eye is not as strong as it used to be, and we cannot withstand small amounts of trauma, things like that. So basically what I'm trying to say is that if we can detect early keratoconus and treat it at early with collagen cross-linking and prevent the disease progressing into a stage where you require grafting, it's really good. So it's good for the patient, it's good for the healthcare sector as well. So detecting keratoconus has to be done early, and it has to be done by being suspicious in this age group, the teenage years. You have to monitor their spectacle errors and whether they require spectacles, say every 4 to 6 months, whether they need a change in their spectacles. Then you suspect keratoconus and you can refer to an ophthalmologist. So if the take-home messaging is, in a teenage or young adult, if they need frequent change of spectacles, you need to send them immediately to screen for keratoconus. Now let's talk a little bit about refractive surgery, because it's being done currently. It's been done for maybe over a decade now in Sri Lanka as well. So what we do by these laser procedures is we change the shape of the cornea, right? Basically we remove some of the corneal stroma and remodel the cornea shape according to the refractive error. So in myopia, you would want to flatten the cornea. In hypermetropia, you would want to steepen the cornea to increase the eye's ability to converge light rays. So you use a laser, excimer laser, basically to remove this collagen so that you can remodel the shape of the cornea. Now, not everyone is eligible to undergo laser refractive surgery for their refractive errors. Basically, the higher the refractive error is, this is a rough saying, the more collagen or more stroma you need to remodel you need to remove to correct that error. So you need a fairly thick cornea, and also you shouldn't be having ectatic diseases or thinning diseases of the cornea. So if you are having keratoconus, you cannot undergo laser eye surgery. Then basically once you have done the laser procedure, you must be having adequate residual corneal thickness to withstand the eye's pressure and give mechanical support. So you can't remove all of the stroma, so you have to have adequate residual tissue. So the amount of tissue that you are planning to excise will limit the amount of refractive error that can be corrected. So maybe you can't do laser refractive surgery in very high refractive errors, In those kind of patients, however, laser refractive surgery can be beneficial to reduce the spectacle thickness. Basically, you're reducing the error, and they will still need glasses, but the thickness of the glass will be less now. So, small errors, of course, these procedures are quite beneficial. Can you do it for hypermetropia? You can do it for hypermetropia, but generally this is done for astigmatism and myopia. Hypermetropia, because you are trying to make the cornea steeper, you need to remove more stroma than its counterpart, myopia. So, and of course the way you remove is also difficult, and of course the post-operative problems associated like glare and side effects like that will be more with hypermetropic corrections. Presbyopia, correction with refractive surgery, again very controversial, quite unnecessary actually, because the amount of correction that you can do on the cornea is limited. The cornea is a small kind of organ. So you can't, for distance and near, it might be difficult to correct. And of course there is also the element of age related cataract, so later on you might need to remove the cataract anyway. So things like that might limit the necessity to do presbyopic refractive surgery. So basically, for myopes and astigmatism, of course, this is a very good option, especially if you have a mild error. There are many types of laser surgery. SMILE is not available in Sri Lanka, but LASIK and LASIK are available. LASIK and PRK are available in the private sector, and they actually provide a very good outcome in patients and allow them to be spectacle free. So this is just the classification of refractive surgery, just to understand that there are many types of laser procedures, and not all will benefit all types of refractive errors. And of course you have to get the opinion of an experienced refractive surgeon to understand whether your type of refractive error can undergo laser surgery. And of course keratoconus and other ectasias has to be checked for, and those who have cannot undergo. So basically it's a process where selected patients will benefit. So these are the options available for refractive surgery, for laser refractive surgery for refractive errors. So that's all I have to tell you today. Thank you very much for listening.
Thank you, madam, for your excellent lecture. So now it's the question time. And these are the questions we have received in pre-registration, and some have been already explained in the lecture. The questions which have not been answered yet, I would like to read them one by one. Madam, side effects of plastic surgery.
Uh, so, side effects of LASIK surgery can be two types. One is also common for LASIK, which is, I hope you can hear me.
Yes, madam.
Yeah, okay. So, for one type of problems associated with LASIK is flap related. So, you're making a corneal flap initially before you use the excimer laser. So when you use the you cut the cornea and make a flap, that can actually that has a hinge. Basically, you replace the flap once you have done the excimer laser. One problem is the hinge being also cut, so the total corneal flap instead of a hinged flap. So flap related problems may occur. The more commoner type of problem, so that is mostly a surgical issue that can lead to problems. The commoner types of side effects associated with LASIK is glare, halos, and that other kind of visual sort of side effects. Especially these side effects will affect the vision during night time, because the pupil dilates in low lit conditions, and the area where the light enters the eye is more. So the excimer lacy is only done in the central, maybe like central 7 millimeters of cornea. So the peripheral, roughly 7, peripheral rays will refract differently than the central rays during darker periods of the day. So they get nighttime halos and glare with headlights during driving, that kind of thing. So again, these are mostly seen if the refractive error is high before the correction. So if you do a bigger correction, the types of side effects, or the amount of side effects you get is more. But I have to also say that most of the patients who have undergone LASIK surgery don't really complain about the side effects because they have had more issues before with the spectacles, more the sort of say if you have like a scratched pair of spectacles, it will produce more glare than after LASIK. So they actually have less complaints after LASIK than before LASIK. So there are side effects, but generally, if it's a moderate or a low myope or an astigmatic patient, it's very tolerable side effects. LASIK also produces some side effects because you are scraping off the epithelium. There's a bit of pain, and you have to wear a contact lens and so on. But again, those are very short periods of side effects. They're not very, they are very tolerable side effects, let's say. Not permanent side effects are very rare.
Okay, madam. And next question is, are refractive errors permanent?
So myopia is pretty much permanent. So if a child gets a myopic error, spectacle error, they are likely to have that error for the rest of their life. It's not going to myopia, astigmatism, both are like that. Hypermetropia, childhood hypermetropia can correct when they are getting older. But the other two, most of it, the myopia and astigmatism generally lasts your lifetime. Hypermetropia might improve, but likely that it will also stay there, especially if you are like a young adult, then it won't correct. So yeah, they will need permanent, lifelong glasses. So generally, what we advise is when we tell the patient they will require constant use of glasses. Which when you tell that to a child, and especially the child's parents, this is very hard to sort of grasp initially. So what we tell them is you wear the spectacles until you're about 21, 22. If there are no problems, later we can give you options not to wear glasses. Like you can give them contact lenses, you can offer them laser surgery. So you tell the parents and help them understand that later on there are options that they can do for the child not to wear glasses. But when they are young, in school age, it's better to wear glasses because that is the lowest maintenance procedure we can offer and the healthiest.
Thank you, madam. Next question is, any prevention measures or can we early diagnosis?
So I think we spoke about it in the lecture
Yes,
as well. For little children, I think worried parents are likely to ask about very young children. So in very young children, we ask the parents to monitor them. Say if the child moves very close to the television or an object, when they are looking at an object, they want to move the object very close to the eye to look at it, then you might want to check their visual acuity and screen for a refractive error. Or if they're having squints, or maybe Little children hardly ever complain of headache, but if they complain of headache, you might want to consider refractive errors. Preventive measures, like I said, definitely we have to promote outdoor activities more and less screen time. If they are using screens, which is inevitable, best thing to do is to ask them to use it on a table. They'll use the screen on a table, because if they are using it on while they are sleeping or lying down, they tend to move the screen or the phone towards their face because of gravity. So because of that, if they are using a screen or any kind of screen, basically you ask them to sit on a chair and keep the screen at about 30 centimeter distance, and then look at the screen. So basically get them to look at you make sure that they don't go close to an object to look at it. And also you promote outdoor activities like sports. The majority of the time during the day has to be spent looking at distance objects or outdoor things rather than near things. So that's what we can do to prevent basically. You can't really stop myopia from, especially genetically susceptible individuals. It's difficult to stop it from happening. But adult onset ones, with outdoor activities, you can reduce a lot.
Thank you,
Shall
madam.
we?
In the next question, the second and third one you have already answered. And the first one, patients with refractive errors, how frequently should they recheck their vision?
Vision. So for children, like I said, because we are worried about things like keratoconus, and they are unlikely to complain about a reduction in their vision with the spectacles unless you ask them specifically. We like to check them maybe once every 6 to 9 months. 10, 12-year-olds, maybe up to about 15 years, you might want to check them quite frequently, because one thing is you want to detect things like keratoconus as early as possible before the vision starts to decrease to a point where it is irreversible. The other reason is you want them to have a better ability to see and for their schoolwork. So if their spectacles are not giving them enough vision, their schoolwork might drop. They might not be able to do well at school. So because of those reasons, we like to check children's eyes quite frequently. Adult eyes, maybe in that, say if they're having myopia or astigmatism, maybe once a year would be adequate. Once it has stopped progressing, and for the last couple of years it has not progressed, then of course if, they can wait until they notice that their vision is reducing, or if their spectacles break or they need a new pair of glasses, then you can just ask them to come for a checkup. Presbyopes, on the other hand, every 2 to 3 years, we would like to recheck their vision.
Thank you, madam.
Next,
question number 5 also, you have given an explanation. And in question number 6, common refractive errors are advised to be given in GP practice, and any other disease need to be excluded when to refer to specialist care.
Common refractive errors and advice to be given in GP practice. So these are the most common commonest that we would encounter would be myopia and astigmatism, I think, in the young adult population, and in the older age group, presbyopia would be the commonest thing. So rarely you would get these irregular astigmatism and all of these things due to scarring and things like that. So advice to be given in GP practice are those things. I think one is this keratoconus. In young children, I would advise people in general GP practice to be aware that if you are seeing children requiring a change in the glasses frequently, to check for keratoconus. The other thing is to refer them to get their eyes checked frequently in children. Those are the main things, and also for these are the advice I would give for refractive errors. Other things is if there is a stable patient who had been on the same spectacles for the last 5-6 years, and sudden reduction in vision, that may not be due to a refractive error, that might be a intraocular problem, maybe undiagnosed diabetic retinopathy or something like that. So in those cases, you might want to refer. That's almost all the things that I could tell about refractive errors, really. Yeah. And
Thank
the
you,
second
madam.
question, any other diseases need to be excluded and when to refer to specialist care? I don't think any other disease. So when they come with headache, uh, one reason for their headache could be frontal sinusitis. So if they are having frontal sinus tenderness or something like that, you might want to treat the sinusitis first, and yeah, all other measures fail, then refer to an ophthalmologist for the eyes to be checked. And when to refer is, I think if it's they are not happy with the correction given by an optometrist, you can refer. Or if they, like I said, if you are suspecting keratoconus, you can refer.
Thank you,
Yeah.
madam. And we have 2 more questions in the chat. Madam,
Okay.
is it advisable to do LASIK for myopia after age of 35 years?
It again depends on the patient. So you have another 5 years before you get presbyopia. So within that period, I mean, you can correct the distant vision error, right? And you can be spectacle free. But for reading, you might need a reading glass because, like I said in the lecture, presbyopia for both, I mean, correction of both distance and near is difficult with laser procedures. So you would only want to correct one, which is generally the distance error. So if you correct the distance error, you will be left with a near vision error, which will manifest maybe at 38 or 40. Especially in a myope, it might manifest a little earlier than normal because they have an accommodation sort of lag. So if you are happy, you can go ahead with LASIK surgery. But you have to remember that at 40 years, you might need or 40 or before, you might need a reading glass. Up to now, you probably didn't need, if you were left with the myopia and spectacle correction, you probably wouldn't need a reading glass because you can always just take the spectacles off and look at the near object. But once the LASIK is corrected, you will need a spectacle for reading. So if you don't mind that, you can go ahead with LASIK at 35 years. Not an issue. Even for patients younger, say 20, 25, 18-year-olds, if you do LASIK, they will need reading glasses at 40. But the only thing is they will benefit from being spectacle free for longer because they have a longer period before they turn 40. For a 35-year-old, you have only 5 more years, or even might be a little less. So, but you won't be completely spectacle free. You might need a reading glass soon. So that's the only thing. If you're happy with it, you can go ahead.
There's one more question, madam. Please give
Okay.
general eye care and eye exercise.
So, general eye care, I think one thing we can, especially I think patients are probably asking about this computer vision syndrome and things. So in those patients, you are with screens, you can get dry eye a lot because your blink rate reduces, and also the glare from the device also makes your eye dry. So because, and also the environment, if you're in an air conditioned environment, you're likely to have dry eye. So general eye care is wash your face. When you are washing your face in the morning and evening, wash your eyelashes as well. Close your eyes, wash your eyes, no water in, but wash your eyelashes clean, keep your eyes clean. And if you are using screens, Try to take a break every 20 to 30 minutes and look at an outside thing like a tree or something far away. If you are unable to sit near a window, you close your eyes for 20 seconds every 20 minutes. So that you can tell them. Use the screens at a distance of at least 20 to 30 centimeters, like we said earlier. And then those are the eye care advice in general that we can give. Then exercises, there aren't any specific exercises, but more outdoor activities, more maybe like have a walk in the evening, look at things outside. If you are, especially if you're working or studying a lot, take a break from that during the day. And also they can have, especially young kids, one other thing, they can have headache due to convergence issues. Their eyes don't converge well. If they are reading, your eyes has to move towards each other when you are looking at near objects. Some patients don't have enough convergence, and that also causes a headache. So only exercise I would tell a patient would be to look at outside objects once in a while, every day. And also, if you are having a convergence insufficiency, do convergence exercise. Move a pencil towards your eye and keep looking at it, and increase your convergence daily. That's the only advice that I can give them.
Yeah, in the absence of further questions, madam, let's conclude today's webinar.
Yes.
And our sincere thanks to Dr. Medhavini Dissanayake, Acting Consultant Eye Surgeon, National Eye Hospital of Sri Lanka, for her excellent lecture and the precious time. Thank you very much, madam. And thank you for the participation. Please fill the link in the chat box and kindly give your feedback and receive your e-certificate for participation. Thank you.